Hello, good afternoon, everyone. I welcome you all for the yet another session of Indian Fertility Society. So, for today's session, we are having Dr. Puneet Rana Arora with us. To talk about Dr. Arora, she has an MBBS, MS, MRCOG from UK, MSc in Reproduction and Development from UK, also fellowship in liver transplantation from King's College London. She is a senior consultant reproductive medicine and assisted reproduction, infertility and oncofertility. She is a director, Center for Infertility and Assisted Reproduction, senior consultant in Milan Fertility, executive member in Indian Fertility Society. She is a founder member and founder joint secretary, Fertility Preservation Society of India. And she'll be delivering her talk on the topic fertility preservation techniques, basic understanding. So, Madam Dr. Arora, I'll hand over the session to you now.
Thank you very much for the very kind introduction. Good afternoon, everybody. At the outset, I would like to thank Indian Fertility Society, team of Zydus and team of DocMode for this wonderful academic initiative series, which has been going on for the last few months. So my today's topic is kind of a sub-specialized field of reproductive medicine, talking about fertility preservation techniques and basic understanding. So in next half an hour, 40 minutes, I will be talking about what exactly is fertility preservation, why is it indicated, what are the various techniques, and what are the various challenges we see when we offer these techniques to our patients. So understanding what exactly is fertility preservation. So it's an emerging field that provides opportunity to maintain the reproductive health to all those women and men who either have to receive medical treatment or want to preserve their gametes, i.e. sperm, eggs, to postpone childbearing, which means because we all know that there is an age-related decline in the fertility. So basically preserving the fertility at the right age. So basically it means putting fertility on hold, preserving it. It's not something we are talking very new. It has been practiced for at least 50 odd years using various kind of techniques, which we will be speaking shortly, like pelvic sparing surgeries, radiation, use of radiation fields, semen banking. But as our reproductive medicine specialty is advancing, our ART techniques are becoming more scientific. Its use and awareness is growing, and hence the topic for today. The first child, I would say, born after preservation of fertility was by embryo cryopreservation back in 1996, where the embryos were cryopreserved in natural cycle IVF and were used for women with breast cancer. And since then, I would say there has been no looking back because there was a success noted in this particular case. So exactly in what scenarios we are talking about fertility preservation? We're talking about fertility preservation in cases where cancer is diagnosed or in conditions where there is an associated medical problem which can lead to a decline in fertility, i.e. decline in number of sperms, number of eggs, medical conditions like lupus, glomerulonephritis, myelodysplasia, arthritis, Turner mosaic syndrome. All these can lead to decline in our sperms and eggs. And lastly, we're talking about the social freezing, social fertility preservation, where there is no medical indication. It's just a woman is trying to delay her childbearing and hence wants to preserve her fertility. So social freezing, talking about that first, it's basically halting the biological clock, because we all know that with time and age, the number of eggs in the ovary of a woman declines with age. So hence, to put a stop on this comes the concept of social freezing, freezing the oocytes. So why exactly this is happening? Like I said, there is a shift in the socioeconomic and reproductive behavior. Women and men want to postpone their parenthood, maybe because of educational reasons, career aspirations, maybe late marriage, not finding the right person, more frequent marital and relationship breakdowns, and idealized parenthood because they need to be completely free when they want to, when they want a child, They do not want to commit to parenthood when they are actively working. And so all these things has led to the concept of social egg freezing. Now, talking about the other aspect, where exactly the majority of the freezing happens, is the cancer. This is a WHO fact sheet, which shows that cancer is a leading cause of disease worldwide. This is obviously a little old figure, but an estimated 14.1 million new cancer cases are happening, and this number has increased. And most of them were breast cancer patients. But at the same time, the good news is if the incidence of cancer is increasing, we see that our 5-year survival rate is increasing, which means the treatment offered for cancer patients is improving. Patients are living more after cancer treatment. It is no longer a disease of death. Women and men do survive cancer at a very good rate. So when they survive, what we see is the late side effects of these cancer treatment, and sometimes the cancer itself. So the late side effects can be neurological, GI side effects, some secondary primary cancers, cardiovascular toxicity, respiratory complications, urological, musculoskeletal, and fertility. Very, very important. So that's what our discussion is about. The rest of the discussion, effect of fertility with the cancer treatment. And when we talk about the cancer treatment, we talk about chemotherapies. There are certain chemotherapies which are definitely more risk to gametes, to eggs and sperms, and the rest, like alkylating agents, cyclophosphamide, chlorambucil, malphilan, procarbazine, are very high risk. And if a woman or a male is receiving such chemotherapy, we should discuss about fertility preservation. The low risk, like methotrexate, 5-fluorouracil, vincristine, bleomycin, these are all low risk, which means that the risk of now the interesting point is when we talk about the risk, it's not the risk of fertility, it's the risk of bringing back the menstrual cycle to its regularity, the onset of menstrual cycle after the finishing of the cancer treatment. So over here, the risk is not calculating on the fertility. And we all know that, getting regular menstrual cycles may not be related to fertility. So it's a little complex situation. So, but we also know that high risk, if a woman stops her menstrual cycle, then there's a high likelihood that, she will have problems in conceiving. And then hence, to freeze her eggs would be, or embryos would be a better option. And also we know that we have got this understanding with the work being done by the oncologist and by the fertility specialist, that there are certain types of cancers which are more prone to affect our fertility, like Hodgkin's, breast cancers, and male or females receiving bone marrow transplant. So our counseling is very much dependent on these figures. Again, but same with radiotherapy, and we're talking about males now. So chemotherapy and radiotherapy, azoospermia or complete absence of sperms is mainly seen if a male receives a dose of 4 to 6 gray or fragmented dose of more than 1.2 gray or a total body irradiation. So if a male is receiving such doses in the pelvic area, he is very at risk of exhausting his sperms. So it's an idea to talk about fertility preservation. Again, the same with the chemotherapy, as we spoke about in females, the same alkylating agents are quite high risk for azoospermia or absence of sperm in the semen ejaculate. So cancer treatment can negatively impact all aspects of the female reproductive axis. And we all know that ovary is a tremendous source of fertility preservation options, because we have an ovary which has got the oocytes and the stroma. So we can either collect the eggs, we can collect the tissue. So there are a lot of options being played around to give an optimum success rate of these techniques. And not only it's the preservation of fertility, but it's also the long-term health of a female, reducing the menopause and symptoms, cardiovascular health, and bone health is also kind of seen as a beneficial effect when we offer fertility preservation. Obviously, it's not seen when a woman is undergoing the oocyte cryopreservation, but with ovarian tissue cryopreservation. So I'm speaking these terms, but I will be discussing all of them in the next subsequent slides. So when we speak about the ovarian tissue, that ovarian tissue is not only giving us follicles or eggs, but it's also giving us hormones. So that's the future. Maybe, freezing ovarian tissue may help not only to preserve the fertility, but also to prevent menopausal symptoms in a woman. So, what are the various modes of protection or cryopreservation which we can offer in these circumstances? In female, it can be embryo cryopreservation, oocyte, ovarian tissue cryopreservation, ovarian transposition, taking the ovaries out of the view from the radiation, mainly given in the radiation settings, offering fertility sparing surgeries, and the use of gonadal protective agents like GnRH analogs. In male, it is semen freezing, testicular sperm freezing, testicular tissue freezing, testicular shielding, and if they're married, obviously offering an embryo cryopreservation. So these are the various techniques which are being discussed and offered. Now, not all of them are standard, not all of them are practiced. Some of them are under research. So exactly, we need to know which of them are under research settings and which of them are tried and tested. But before we offer this, it's very, very important that we understand the basic principles of fertility preservation. That we know that the patients are suffering from cancer or maybe social freezing. They want, their gametes to be frozen as soon as possible. So the definitive treatment should be started as soon as possible. The procedure should be carried out before the chemotherapy and never in between the treatment. Very, very important, because sometimes, you get patients when they have had one dose of chemotherapy and they say, okay, we have now 3 weeks in between. Can you preserve their eggs or sperms? And you can do that, but there are studies which have shown that the effect of even a single dose of chemotherapy is as equally nasty as the whole dose of chemotherapy. Very important aspect, counseling. There should be a team of oncologists, fertility preservation specialists, psychosocial counselors when we offer these services. Appropriate consent forms, very, very important, because even though we know that the survivorship is increasing, but there should always be a room for consent for posthumous use of gametes. So in case something happened to patient, what is going to happen to the gametes? And also when they plan for pregnancy, it should only be planned after 6 months or so after completion of chemotherapy. So when we talk about, which are the standard kind of a preservation techniques to offer and which are experimental. So embryo freezing is a standard technique. This is as per the 2013 guideline. Egg freezing is now standard. Ovarian tissue, very much experimental. Ovarian transposition, very standard. So basically considered in patients where the radiation is being considered. Ovarian suppression with GnRH analogs is experimental, even though there has been a recent study on breast cancer, but in rest of the other cancers, it's very much experimental. And radical trachelectomy, which is a fertility sparing surgery, that's also a standard kind of a protocol or a treatment given for preserving fertility. And then we talk about the alternate methods of achieving pregnancy, like donor eggs, donor embryos, surrogacy adoption, in case the patient has not had a chance to preserve their fertility. And if we see at this yellow bar, all these treatments can be given before treatment. The GnRH analog can be given during treatment. So when we see patients, who come in between the cancer treatment, obviously we can't offer them embryo and egg freezing, but we can offer them GnRH analogs. At least it may do some benefit and not doing much harm. So these are the more standard embryo freezing and egg freezing. If we talk about males, so we have sperm banking with alternate collection methods like through testicular aspiration or extraction, electroejaculation, standard. All of these are standard methods of offering fertility preservation. Testicular tissue freezing, very much experimental. Testicular sperm extraction, in case a male is not being able to give an ejaculate sample, we can get it through the testicular sperm extraction by a very small surgical procedure. Radiation test shielding of testes, this is like a protective mechanism to protect testes from the exposure of radiation in the pelvic area. And in case a male hasn't had the opportunity to preserve his sperms, then the use of donor sperm and adoption obviously becomes the other methods. So in this, you can see the testicular tissue freezing is experimental, and this in fact is the only treatment which is available at the moment if a male or a child has not started the puberty. Because sperm banking can be done after puberty, sperm banking after puberty, testicular sperm extraction after puberty. So in a way, we see that the only option which is offered before puberty is still experimental. So I mean, essentially, there is not much to offer in the young boys. So boys who have not attained fertility at the moment, there's not much to offer until unless you are offering them testicular tissue freezing in a research setting. So this finishes more or less, I would say, what are the various techniques available. Now let's see what are the challenges with them. So first of all, let's talk about stimulation of ovaries. So we will need stimulation of the ovaries to freeze eggs and also for the embryo freezing. So these two scenarios need hormonal stimulation. So it all depends that when we stimulate the such patients, we need to know the nature of the tumor, especially in breast cancer patients. Because hormone sensitive tumors, we know that breast cancer can be hormone sensitive or non-sensitive. So especially with the hormone sensitive tumors, we have to kind of modify our stimulation protocols. Conventional protocols, which I will discuss, basically this mandates the start of ovarian stimulation with the menstrual cycle. But we know that cancer can be diagnosed at any time. So waiting till the menstrual cycle can cause delay in the cancer treatment, which our oncologist colleagues are not very happy with. So our understanding has increased, and hence we are able to start and give protocols at any part of the menstrual cycle, which what we called as random start stimulation protocols, which I'm going to discuss in the next slides. And above all, we should know the outcome of our stimulation and cryopreservation. Very important, because if we offer to patients, patients will ask us, what is the success of this treatment? Will I be able to use it? How will my eggs and sperms come out after freezing? So we should have our own data to present to our patients. And also, there has been an association between the use of exogenous estrogens and recurrence of breast cancer. So that's another question which is asked by our patients, that if I'm going to have a hormonal stimulation, is it going to worsen my cancer, especially the breast cancer? So we should have an efficient counseling system and a psychosocial support system to offer when we offer the fertility preservation services. Now, to overcome the challenges of hormonal stimulation, we have these three parameters in place. First, we have learned to keep our estradiol levels at low, because we know that some tumors can be hormone sensitive. So we have softer stimulation protocols, and we have a method of using letrozole and tamoxifen, use of agonist trigger, avoiding OHSS. So all these will make patient, at a low risk of getting any complications while using the fertility preservation techniques. Antagonist protocols are always preferred in such scenarios. And very important, we should be, comfortable, and also, we should be able to counsel our patients for the random start protocols, which means that stimulation can be started on any day of the cycle. And hence the protocols are different from the conventional ones. So what is this random start protocols? We know that from the follicular recruitment theory now, there is kind of a multiple waves of recruitment. Initially, it used to be there was a single wave of recruitment, which means a cohort of 2 to 5 follicle is recruited once in the menstrual cycle. But multiple wave means that there are 2 to 3 synchronous growth of groups of antral follicles, which occurs at regular intervals during the menstrual cycles. So we can utilize this multiple waves for stimulation, because if there are 2 to 3 waves, let's say that we need to know which part of the menstrual cycle the patient comes in, whether the patient comes in the follicular phase, luteal phase. So we should be able to recognize that, because we know that the recruitment is happening continuously. This is very, very important concept which we should understand to offer our patients, especially cancer patients, throughout round-the-clock fertility preservation techniques. So and it has been shown very clearly that existence of healthy antral follicles in the luteal phase is attributed and give us a healthy cohort of follicles, and has been associated with live pregnancy rates. So healthy antral follicles are available for recruitment in all phases of menstrual cycle. So if we come back to the conventional protocol, we know that there are two kinds of protocols: the agonist protocol and the antagonist protocol. Agonist protocol can be short, long, ultra long, and antagonist can be with oral agents or just with gonadotrophin. So in this particular convention day, the ovarian stimulation starts from day 2 of the menstruation. So this is our antagonist conventional protocol where we start from day 2 of the period, uh, gonadotrophins, and on the day 5, day 6, or day 4, flexibly we start antagonist. When the follicle is between 12 to 14 the antagonist is started. It takes 12 to 14 days to complete the ovarian stimulation, 8 to 10 days of the stimulation, and then finally a trigger either with HCG. But in patients with cancer, we should prefer the GnRH agonist trigger to prevent the risk of OHSS. Long protocol, the stimulation starts in the preceding month on the day 21 of the cycle. The agonist continues with the bleed. We start the gonadotrophins. So there is no use of antagonist, but the agonist is started in the preceding months. It takes longer to complete. So for cancer patients, this protocol definitely is not recommended because it's taking 10 to 14 days extra. We are talking about the protocols which are as shorter as possible and can be started at any part of the menstrual cycle. The rest is same, that when the follicles are mature between 18 to 20 it's triggered either with HCG or the agonist trigger. Now, for the random start protocol, it's very important to understand which phase of the menstrual cycle the patient is. So we generally divide it into an early follicular phase, late follicular phase, and the luteal phase. So categorization, how it is done. So generally, this is a very kind of a crude and a broad way of dividing the phases of the menstrual cycle. The early follicular phase, when all the follicles are less than 10 millimeter. The late follicular phase, generally from the menstrual cycle, day 7 onwards, when the dominant follicle is between 12 to 13 or more, and the progesterone level is less than 2. The luteal phase is generally diagnosed when the progesterone level is more than 3. So these are the ways where we kind of diagnose what part of the cycle the patient is, and hence we start our stimulation protocols. Generally, E2, progesterone, and LH levels are measured as a baseline to help us gauge which part of the follicular phase or luteal phase they are. And the stimulation is started within 2 to 3 days, of initial consultation. Whether we need to do some priming before or not will depend on the phase of the menstrual cycle. The next question is, in case we follow random protocols or we give convention protocols, is the number of oocyte retrieve affected by cancer itself? Because we may be offering all these to cancer patients, but do they respond similarly as our non-cancer patients? So now we have enough data to say that the oocyte retrieval number is not reduced, right? There are some studies initially where it was said that the number is reduced, but there are a lot of studies which are coming up that say that the oocyte number is not reduced. And I think this all variation has been because of the phase of the menstrual cycle in which it started. So the good results definitely are obtained in the luteal phase and the early follicular phase. The late follicular phase and the early luteal phase are a bit tricky, and it has been seen that the kind of oocyte retrieve were slightly less in number than the other phase protocols. So do the cancer patients respond, similarly in IVF cycles as, non-cancer patients? The ovarian response somehow has been, expected as per the age. Cancer itself has not been shown to affect much on the oocyte quality and on the success of embryo or oocyte freezing. But we all know that, especially in patients with lymphomas, they may have a difference, because lymphomas have been shown, patients have been shown to have little subtle changes in their gametes, either the sperm quality or the oocyte or the AMH. And hence, if these are altered, then we can expect a kind of a change in our oocyte retrieval rate, and hence the freezing, and hence the live birth. So coming to the next, so this is all about the hormonal, stimulation. Coming to the next aspect is the ovarian tissue cryopreservation, which we discussed in our initial chart, that it is still the kind of it's not standard procedure for offering fertility preservation. It is more an experimental at the moment, but hopefully with the way it is progressing, it should be a standard very soon. The ovarian tissue cryopreservation. So if we see, this is the cut section of the ovary. So these all kind of a translucent are the follicles. This is the stroma. So basically taking strips of the ovary and preserving them in small slices. They can be frozen by slow freezing or by vitrification. So tissue can be collected either through laparoscopy or laparotomy, and the biopsies can be taken either, if it has been shown, if the child is prepubertal, even the whole ovary has been, taken out and preserved. So once it's taken out, it is cut into small slices, and then, later stage when it has to put back, it is put back either in the remnant ovary or in the, in the fossa, in the pelvic fossa. So when it comes to transplanting back this tissue, either it can be put at the same site or it can be put at a different site. Obviously, there are more pregnancies when it was put back in the ovary or in the pelvic fossa. So this is just a kind of a detailed, description about what is done. These are all the ovarian cortical tissues, and these are put back in the ovary, in the subcortical pockets. So this is again, where the heterotropic transplantation has happened. In the abdominal wall, it was inserted, and pregnancy has been reported from here also. So what are the factors which affects this procedure success? It can be, where do we put it back? How is the vascular bed being maintained? Environmental factors, operative technique, ischemic period, thickness, volume, a lot of things which affect the success of this. Because it also depends how tissues are dissected, how thin they are dissected, how heavy they are, because all these have been shown to affect our success. Now, like I said before, the advantage of this particular technique is not only the fertility is being reduced, but it also helps to alleviate the menopausal symptoms. And if it has been done prepubertal for young girls, it also helps in induction of puberty because it's giving back the hormones. The ovary is the source of hormones. So putting it back gives us back the hormones, and we don't have to give any exogenous hormones to attain puberty. So a lot of advantages. So there's a lot of potential. It's already being shown that it's working well, and I think it's just to be offered more and used more. So advantages of ovarian tissue is it does not need prior ovarian stimulation. It can be done immediately. It doesn't even need 12 days or so, because even if we do random start protocols, still we need 12 days for ovarian stimulation, but it doesn't need any kind of that time lag. The biggest advantage is it can restore both endocrine and reproductive ovarian function. And sometimes it may be the only fertility preservation option suitable for prepubertal girls or for young women with estrogen-sensitive malignancies. Now, why we are so confident about fertility preservation is that because we are confident with our cryopreservation. Cryopreservation is the key when we offer fertility preservation, because the tissue has to be frozen. So it's very important to keep in mind that when you speak about fertility preservation to your patients, it's important that you have a good cryopreservation facilities. So what is cryopreservation? It's a process of cooling and storing cell tissues or organs at a very low temperature. We know that there are two ways of freezing. One is the slow freezing, where it takes around 110 minutes to freeze a tissue, and the vitrification, which takes seconds to freeze the tissue. Now, all embryo and egg freezing are being done by vitrification. The ovarian tissue freezing is being offered. All the success so far has been with the slow freezing, very few cases with the vitrification. So over ovarian tissue, we still have to work out which is the best method, even though right now it's the slow freezing. But for ovarian and oocyte and embryo cryopreservation, we know that vitrification is the successful method because there is less ice formation, the freezing is very rapid. This is the same technique showing that how quickly they are put in the liquid nitrogen, and over here slow freezing and vitrification. So coming out of freezing, and is the other methods, medical methods by which we can offer fertility preservation. One is the gonadal protection. or ovarian transposition. So these two are the methods where nothing is being done from freezing point of view, but we are still trying to preserve our gametes. So if we talk about ovarian transposition, it is generally indicated when the whole body radiation is planned, and when the pelvic area is specifically involved. The next, non-cryopreservation fertility preservation technique is the fertility sparing surgeries. So whenever a surgery involving the pelvic organs, we can do it at such a kind of we can offer such surgeries which do not involve removal of uterus and ovaries. Like in patients with cervical cancer, we can offer simple trachelectomy or conization. Or if it's an ovarian tumor, you can offer cystectomy, and also the surgery in men. So we can think about fertility, freezing is one aspect, but talking about fertility sparing surgery is also very important, to avoid the loss of gametes. So we've spoken about females a lot. About the males, now we know that it's testicular tissue, testicular extraction, semen, ejaculate sample freezing. So if the boys are prepubertal or postpubertal, so it's because for the adults we know it's semen freezing or maybe testicle extraction. But the challenge is when we see young adolescent. So in those cases, it's important that whether the boy is a prepubertal or postpubertal. If it's postpubertal, they behave like adults. So we can offer them straight the sperm freezing. If they're pre-pubertal, then the testicular tissue sampling is done, which is obviously experimental. And that has to be in discussion, tomorrow, whether if we freeze the tissue, it's going to give us sperms or not. That's a question mark. So cryopreservation of sperm should be offered to all cancer patients in reproductive age group, regardless of the risk of gonadal failure. Coming to the last aspect is the pharmacological protection. So use of GnRH agonist and use of apoptotic inhibitors, which is a very, very new concept which is coming up. Let's talk about the agonist first. This is also known as ovariostasis or ovarian suppression. It is generally given patients with chemotherapy. It does not offer any benefit in radiation-induced injuries. So reassuring results have been found in animal models and now recently in the breast cancer human models, but controversial in other tumors. So this is just kind of evidence-based data. There have been 20 studies so far, and which have shown a significant decrease in premature ovarian failure rate in the survivors. There were 7 meta-analyses where GnRH has shown beneficial effect. But if we look at these studies, they were all talking about the premature ovarian failure. They did not look into the pregnancy outcome. So basically, like I said, even the chemotherapy, they look into the ovarian failure concept, which means the onset or onset of menstrual cycles. But they haven't spoken about But when we talk about premature ovarian failure, GnRH is beneficial. But when we talk about the incidence of spontaneous ovulation and spontaneous pregnancy, so spontaneous ovulation still GnRH may be helpful. But when we talk about spontaneous pregnancy, GnRH plus minus. So again, it's a very, very controversial, like I said, little confident in breast cancer patients, but not in other cancer patients. Lastly, it's a sphingosine 1-phosphate, which is an ovarian protective agent. It's a very new concept, that it can be given along with the patients receiving chemotherapy. More data and research is needed from all these ovarian protection regimes. So just to conclude, fertility preservation can be offered as a medical indication or as a social indication. Strict protocols and SOPs should be there while offering fertility preservation. Very, very important that a dedicated team of clinicians, counselors, and laboratory personnel should be available for provision of these services, because this not only it's not a single person kind of a treatment. It involves proper counseling, proper effects, role of clinician in offering these services, and a very good cryopreservation systems available in the laboratory. And also, even if you're offering a medical protection, it's important that the clinician and counselor should discuss as to how much to expect of the return of fertility after use of these medical treatments. So it's very important. Communication is the key when we offer fertility preservation. Yes, offering them is a good thing, and it's, our science is advancing, but at the same time we should understand the limitations of it. And that's all for now. Thank you so much.
Okay, madam, we'll go for the question and answer session now.
So, shall I speak the question, Tejas?
Yes, ma'am, please.
Okay. So this is a question from Manisha from Mumbai. Thank you for this question. What should be the duration of preservation before the chemo session? So, what should be the duration of preservation before the chemo session? Sorry, I mean, are you asking about the oocyte cryopreservation? May I know? What should be the duration of preservation before the chemo session? So, sorry.
Madam, we can go for the next question. Let her collect the question then.
Okay. So it's a question from Delhi by Sagar P. GnRH is recommended at all conditions. I would say that, GnRH is one where it should be recommended in patients receiving chemotherapy. Obviously, it's not indicated in patients receiving radiotherapy, but yes, in patients receiving chemotherapy, it will help to preserve our gametes. Its role is more studied in breast cancer patients, but for other cancer patients and in male patients, we have to counsel them and say, its role is plus minus. So it's basically, again, like I said, it's a communication, because a lot of these do not have full-fledged studies. So we have to talk to them, but as such, GnRH has got not much side effects. So you can recommend it in conditions where exactly its role has not been much studied, like beyond breast cancers also. So the next question is by Suhana Mani from Amravati. How do you select methods of preservation according to which condition? So that's an interesting question, because that's very important. So let's talk about the oncofertility first. So in oncofertility, like I said, the standards are, in females, it's oocyte and embryo. So we can offer if a female comes to us, then we can offer them oocyte cryopreservation or embryo cryopreservation. If it's a male patient, we offer them semen cryopreservation. But yes, at the same time, if they're married and have been planning to conceive, even in males also, we can do the embryo cryopreservation. But obviously, for that, female has to undergo stimulation. So it all depends on the patient. And also it depends upon the age of the patient. Like I said, there are certain techniques which are not available, pre-pubertal and post-pubertal. So if it's a pre-pubertal, obviously we cannot offer oocyte and embryo. We have to offer ovarian tissue. And in the in the pre-pubertal boys, it has to be testicular tissue. So it all depends upon the age of the patient, the type of cancer, and also the underlying ovarian reserve or the underlying parameters of the patient. The next question is from Sita. What percentage of approximately cancer patients have good response to IVF? So I would say in this particular question, cancer patients, again, you will assess the patients as per the parameters we do for the ovarian stimulation, like age of the patient, underlying ovarian reserve of the patients. If all these parameters are good, and if they've not received or started any cancer treatment like chemotherapy or radiotherapy, the response is generally good with such patients. And hence, the active discussion about fertility preservation should happen. The next question is Leena Chaturvedi. What should be done in ovarian suppression in premenopausal breast cancer? So ovarian suppression, I would say that, ovarian suppression can be achieved with GnRH analog. The recent trial has shown a promising role of GnRH in breast cancer. So I will say breast cancer is the only one which has been, studied, and it gives us, good results, especially in the breast cancer patients. Next question is from Ahmedabad. Dose of GnRH and how long? Generally, I would say that we start the first dose of GnRH. We recommend to start a week before chemotherapy if the patient visits us. But in case the patients are going to start tomorrow, even giving them a day before is also fine. But if we have time, giving them a week before is always beneficial. And generally we continue till their it's a weekly depot injection you can give, or a 3 monthly depot injection. And generally we continue while they are having their cycles of chemotherapy. In some cancers they receive 3 months of chemotherapy regimens, in some 6 months. So we keep on continuing them till they finish their chemotherapy. The next question is from Delhi. In what situation do you use ovarian suppression? Like I said, in conditions where the time doesn't permit us to offer any other fertility preservation, like oocyte freezing or ovarian tissue, or especially in also blood tumors, leukemias, and all. In such cases, ovarian suppression can be offered to them.
I think we're done with the questions then.
Okay. So just kind of, I would say, yeah, sorry.
No, ma'am, please go on.
Yeah.
Yeah.
So just I want to kind of a take-home message would be that yes, fertility preservation is a subspecialized kind of aspect of reproductive medicine, where we are preserving the gametes. For that, to begin with, I would say counseling is the important, and then what to offer. And I think that question was covered as well. That what to offer is very important, when to offer, and how to maximizes the chance of success is where the your lab comes into picture. So it's like a teamwork, and if you have a good team in place, the results are good. I have been practicing oncofertility, and obviously we haven't used those gametes, but we have used especially the semen frozen from our cancer patients, and with very, very good outcomes. So it does give us hope. Freezing, it does give us success. I've already also used the eggs frozen after social freezing with very good success rates. So it does, like I said, it has to be a complete holistic teamwork to offer these fertility preservation techniques.
So, there are no more questions now. We can end the session then.
So,
Ma'am, there is one more question from Dr. Avani from Mumbai. She's asking ovarian suppression in premenopausal breast cancer.
So, like I said, that DNRH ovarian suppression has been well studied in the recent POEMS trial. Also, the breast cancer is the only cancer which has been extensively studied with GnRH analogs, and the recent trial has shown promising effects. So, and the recent, I would say, the guidelines from the oncology and the fertility societies also say that you can offer more than one fertility preservation techniques. Like, let's say if you're already offered oocyte or embryo freezing, still you can give GnRH analogs. Because let's say if it's a breast cancer patient who's looking to achieve a pregnancy, then you can offer all of them. But if it is a premenopausal breast cancer patient, then obviously you're not looking maybe to preserve gametes. But in those cases, ovarian suppression with GnRH analogs can be given, so that to make sure that they have less post completion of chemotherapy, less menopausal symptoms. So at least some of their follicles are reserved, and hence some of their hormones are preserved, and then they will have less chances of postmenopausal symptoms. So yes, there is a role of GnRH analogs in premenopausal breast cancer patients. And I think the next question is, in hormone receptor negative patient, will you opt for luteinizing hormone releasing hormone agonist for fertility preservation patients? So, I mean, it's one of those things that it has worked better in the hormone receptor positive patients, but not much in the negative patients. So the next question, I think, is after what duration you would advise ET after treatment of carcinoma breast? So it all depends on our oncologist as well. So that's why I said it has to be teamwork. because we need to know whether the carcinoma breast is hormone sensitive or non-hormone sensitive. Because the recent recommendation is, if it is hormone sensitive, you continue them on tamoxifen. Initially, it was 5 years, but now 10 years. So, but you can, if it's a stable cancer, you can give a break in between and plan it. So the minimum I would say is, it all depends on the type of tumor. 6 months, 2 years, definitely not before 6 months. Ideally to wait for 2 years, and it has to be in a constant dialogue with your oncologist as to what they feel is the safe time as well, to start stimulating them for embryo transfer after breast cancer.
I think we're done with all the questions now, ma'am. We can end the session now.
Okay, thank you very much. So thank you, Zaitis, and thank you, DocMode, for this wonderful initiative.